So today we have Dr. Maimuna or Maya Majumder speaking to us. So welcome everyone to this AI Research for Health seminar. It's been a little while, and we're looking forward to more programming and seminars this fall and this academic year. So we have a very special seminar today for several reasons. We have a speaker who is our first speaker outside of the USC community. So that's exciting. And this particular speaker is very close to my heart as a researcher and a friend. Maya and I completed our PhDs together in the engineering systems division at MIT. I'm going to tell you a little bit more about Maya before I let her get started. So her research focuses on using AI and machine learning to tackle public health issues. She's mostly focused on infectious diseases, but also other global health challenges. She's currently an assistant professor at Harvard Medical School and Boston Children's Hospital, where she also serves as the inaugural Peter Solovitz Distinguished Scholar in the Computational Health Informatics program. Like I mentioned, Maya has her PhD from MIT. Her research there focused on modeling disease transmission. She was mainly focused on MERS back then, if I recall correctly, and also showing us the limitations of the reproductive number R0 for modeling and forecasting epidemic spread. Her current work has really focused on pushing the boundaries of how data can be used to improve global public health responses. And she does a lot of work leveraging non-traditional, you could say non-medical data sources, such as search query data, social media data, local news data for outbreak detection, including some notable work early in the COVID-19 pandemic. Also health misinformation. And she also has a large focus on outcome disparities in marginalized communities, particularly around how infectious diseases and access to care can vary across socioeconomic lines. More broadly, she's an advocate of timely dissemination of scientific findings through preprints, and is very involved in public outreach, communicating her own complex research, as well as translating others for the general community. So Maya's going to speak to us today about her research in computational epidemiology during the COVID-19 pandemic, and we are grateful to have her and look forward to her talk. So Maya, without further ado, I will finally let you proceed. So thank you, and look forward to hearing more from you.
Awesome. Thanks so much, Abby. And thanks everyone for having me, and especially for that very wonderful and thorough introduction. I really appreciate it. So just to kind of echo what Abby said, I'm Maya, and today I'm going to be discussing a few of my team's studies at the intersection of computational epidemiology and the COVID-19 pandemic. Okay. My mouse has decided to freeze up. Here we go. There we go. All right. So computational epidemiology, or comp-epi, as I like to call it, is a relatively new, highly interdisciplinary field at the crossroads of digital data, machine learning, and public health. In the Majumder lab, we often leverage digital data sources like search query, mobile phone, and news and social media data, combine them with more traditional health data like case counts and death counts, and then apply techniques from machine learning, including those at the nexus between machine learning and network science, which is an area that I know that Abby cares about quite deeply, to not only improve our scientific understanding of public health problems, but to help shape the health policies used to address them in as just of a way as possible. So I've been working in this space for the last decade or so, and I've spent most of my time responding to global and domestic infectious disease crises, including Zika in Central and South America, Ebola in West Africa, and as Abby mentioned, Middle East Respiratory Syndrome or MERS in the Arab world, as well as measles and mumps right here in the US. But for today's talk, my research regarding the first year of the COVID-19 pandemic is going to be front and center. So we're going to kick things off with a bit of context regarding the pandemic, and then from there, we'll move on to 3 of my team's studies that employ computational epidemiology to better understand COVID-19, with a special focus on problems involving contact networks, mobile networks, and information networks during the first year of the pandemic, as well as the social and justice-oriented impacts of the work. Because we have limited time today, I'm going to be keeping my overview of each study pretty high level, covering the research questions first, then the methods used to address them, followed by findings, policy recommendations, and related work. I know we have a diversity of academic backgrounds in attendance, so my goal throughout this particular seminar is to keep concepts at a high level that's appropriate for folks from across disciplines. But for those who want to learn more, all 3 studies have been published already and are open access. I've included citations throughout the slide deck to make them as easy as possible to find, so please do check them out if you're interested. And finally, I have a lot of time at the end of the lecture for a Q&A. I know our time is limited again, so it'd be really great if we could reserve questions till then for what I'm sure will be a very lively conversation. All right, great. So now let's get started. So as many of us on the line are aware, there have been over 775 million cases of COVID-19 reported worldwide since late 2019, caused by the novel coronavirus SARS-CoV-2, which is shown on the right here. These cases comprise only a fraction of total infections, though, due to something we call underdocumentation. So underdocumentation has many causes, including the fact that many SARS-CoV-2 infections are mild or asymptomatic in nature, as well as an insufficient volume of lab testing in the early days of the pandemic, which is a problem that still persists here in the US now, as at-home testing comprises a larger and larger share of total tests that we conduct on a day-to-day basis. Another reason for underdocumentation in the earliest days of the pandemic was simply because cases were often misclassified. The earliest cases of COVID-19 presented as pneumonia, which can have lots of causes beyond SARS-CoV-2 and may have thus been diagnosed as something else at the time. As is an issue with any novel pathogen, there's a significant and steep learning curve associated with discovering even the most basic attributes of its characteristics in humans and its behavior in our populations. So for instance, the transmission of SARS-CoV-2 started in Hubei, China in late November 2019, approximately. It wasn't really until January 2020 the sustained human-to-human transmission was suspected, which is when my group began researching the novel coronavirus and its many epidemiological characteristics. So our earliest work involved assessing the transmissibility potential, often described as the reproduction number or R naught associated with SARS-CoV-2 in Hubei, China. The base reproduction number is often defined as the average number of secondary infections caused by a single index case in a fully susceptible population. So as a result, it is population specific and it varies across contexts. So one can imagine, for example, populations where individuals have many daily contacts might exhibit higher values of R naught than populations where individuals have fewer daily contacts. In a population where R naught for a given pathogen is estimated to be greater than 1, we expect that the pathogen has epidemic or pandemic potential. That said, because R naught can't be directly observed, we have to model it. There are lots of different models that can let us estimate R naught, but early in the pandemic, we had so little data available that we decided to take a simple phenomenological approach to its estimation. Phenomenological models are strictly descriptive in nature. In other words, they can't tell us anything about the underlying mechanism of disease transmission in the population, but their advantage is that they require very little data to parameterize. So my group's estimate for R naught was the first on record, but was quickly followed by several others, which is shown on the right through a meta-analytical study we conducted in February 2020. Though there was variability across the estimates, as is obvious here, the mean was consistent across studies, indicating that the R naught associated with SARS-CoV-2 in Hubei, China in the earliest days of the pandemic was likely in the ballpark of 2 to 3. But as the epidemic in Hubei quickly turned into a global pandemic, my group started to wonder just how different R naught was across different locations and across different contact networks, and how the various non-pharmaceutical intervention policies that were implemented around the world would impact transmission in the months ahead, especially as new waves of transmission began. Given the complexity of these new questions we were interested in, we decided to take a more complex machine learning approach in the form of agent-based modeling with a focus on simulating public health intervention policies to address them. But, as is often the case in science, these questions led to even more questions. In the months that followed the initial rollout of non-pharmaceutical interventions, we became increasingly curious about compliance with these policies, and in the US, how the federalism of our health policy landscape might have impacted that compliance. In particular, we wanted to understand how pre-existing state-sanctioned policies like paid sick leave may have affected our ability to comply with the work from home and stay-at-home policies in the spring of 2020. And so to answer this question, we turned to data from mobile networks to evaluate the impact of state-sanctioned paid sick leave policies on workplace mobility and therefore workplace disease transmission in the earliest months of the pandemic. That said, it isn't just the American health policy landscape that impacts the health of Americans, it's the broader political landscape and the information networks that it exploits too. Just as non-pharmaceutical intervention policies began to deploy across the US, misinformation about the pandemic began to proliferate, in no small part driven by the Trump administration. Without question, Americans have been uniquely vulnerable to misinformation about COVID-19 because of the political climate here in the US. And so, with an eye towards developing better monitoring and mitigation strategies for health misinformation, my group tapped into search query and news media data that represent the information networks all of us are exposed to on a daily basis to investigate misinformation events here in the US. These three very broad research areas, agent-based models for health policy simulation, smartphone mobility data for health policy evaluation, and search query and news media data for monitoring health misinformation, comprise just a few of my team's core scientific interests. And today, the three studies that I'll be covering offer a taste of the work that we're doing within each of them. So without further ado, let's get started with agent-based models for health policy simulation. The paper I'll be presenting in this research area is cited throughout these slides and was published in PNAS for those who are interested in reading it. In this paper, there were three big picture research questions that we aim to answer through our agent-based modeling approach across three different populations of interest. First, Hubei, China, where the pandemic began. Second, Lombardy, Italy, one of the hardest hit locations worldwide in the earliest days of the pandemic. And three, New York City, one of the hardest hit locations here in the US back in 2020. Recalling again the context dependence of the transmissibility potential associated with the given pathogen, the first question we wanted to answer was, how does R naught vary across locations, given that each location has its own unique contact network? Second, recalling issues with documentation of infections that I mentioned at the very beginning of this presentation, how does documentation rate vary across locations? And finally, recalling the number of non-pharmaceutical intervention policies that have been deployed around the world since the beginning of the pandemic, interventions that we're still employing in some regions today due to lack of vaccine access and emergence of variants. What is the impact of varying policy recommendations during a new wave of infections across locations? Our choice of an agent-based modeling or ABM approach to answer these big picture questions is maybe best explained by digging into what an ABM actually is. ABMs in our use case can be best described as mechanistic infectious disease models that simulate individual people or agents who are assigned predefined characteristics based off of existing data on the population or populations of interest, including things like region-specific contact matrices, household structure, age, sex, and comorbidities, among a whole host of other things. The description cards shown on this slide describe some of the attributes that are defined for a given agent or individual to address the aforementioned variability that we expect across locations and contact networks for our three questions of interest. By defining each agent's characteristics based off of population-specific distributional data, we're able to simulate epidemics within essentially a synthetic version of each population, including how intervention policies might curb disease transmission in these populations. Clearly, ABMs require a lot more data and computing power to parameterize than simpler models, which is part of why we didn't use this kind of approach right away. However, unlike simpler models, they can lend really important insights into the more complex questions like the ones we were interested in answering for this particular study. To simulate epidemics in each of our populations of interest, we fed the agents for any given population through a susceptible, exposed, infectious, and removed, or SEIR style model, as is shown here. We used contact network and household structure data specific to each population of interest to inform transitions from the susceptible state to the exposed state, and we further partitioned our infectious state into 4 categories: pre-symptomatic, mild, severe, and critical, each of which were also assigned a probability of transitioning to one of the 2 removed state categories, recovered or deceased. Folks on the line are probably very familiar with SEIR models of the traditional compartmental variety, which are typically defined by ordinary differential equations and treat each member of a given compartment as identical to one another. In these simpler models, all members of the susceptible compartment have the same probability of transitioning into the exposed compartment. All exposed members have the same probability of transitioning to the infectious compartment, and so on and so forth. These kinds of simple models are popular because they are much less computationally intensive and complex than ABMs, but they aren't optimized for taking into consideration intervention policies and their impact on transmission, an issue that is particularly important for our 3 populations of interest, given that shelter-in-place orders took place at each location early in the pandemic. Moreover, they can't capture the individual level variability that makes agents different from each other, something that's important to bear in mind given that intervention uptake occurs at the individual level. In other words, just because an intervention policy is enacted in a given population doesn't mean that every group within that specific population will actually comply with it. This was really critical to our research interest because we wanted to specifically investigate the impact of age group specific sheltering in place and physical distancing on transmission dynamics during future waves of spread in Hubei, Lombardy, and New York City. To parameterize the SEIR model shown on the previous slide, we used a combination of empirical estimates and a small number of free parameters, as is shown in this table. Notably, the probability of infecting an out-of-household contact is a free parameter that plays a really important role in estimating R0 across populations. Distributions for free parameters like this one were estimated using a Bayesian inference framework by fitting death trajectories for each population of interest against ground truth death trajectory data. Death trajectories were used as opposed to case counts over time because deaths have generally been a more reliable indicator of outbreak progress across locations throughout the pandemic. Though deaths obviously lag behind infections, they are more likely to be documented than non-fatal cases of COVID-19. That said, we did use ground truth data on case counts to estimate the documentation rate across locations by dividing reported case counts by the number of infections as ascertained from our ABM for each location. Our ABM fits against the ground truth daily death data for each population shown in small black dots in the 3 panels in this figure. We're pretty good across locations. The green line shows the median trajectory from our ABMs, and the light blue shows individual samples from the thousands of simulated epidemics that we ran for each location. The red dotted line indicates when ABMs for each location initiated a reduction in contact across the population in response to non-pharmaceutical intervention policies like shelter-in-place orders. These policies were implemented at different times across locations, as should be clear from the x-axis for these 3 panels. The factor by which contact was reduced following shelter-in-place orders varied by location. While information on this parameter was determined empirically from a survey study for Hubei, it was treated as a free parameter for Lombardy and New York. We did, however, compare our estimates for contact reduction in New York against mobile network data and found that our estimates were pretty similar. To further validate our fits against death trajectory ground truth data, we conducted many sensitivity analyses under varying assumptions of underdocumentation for deaths, as well as out-of-sample validation, which is detailed in the supplementary materials that accompany this paper. Once we felt really certain that our fits against the ground truth death trajectory data were in pretty good shape, we were able to estimate R0 for each location, as well as the documentation rate. Substantial differences in R0 were visible across locations in the early days of the pandemic, as is shown in the top left panel here, with medians of 2.23 for Hubei, 2.95 in Lombardy, and 3.2 in New York City, demonstrating really important population level variability. R0 values, as estimated through a sensitivity analysis in which deaths were assumed to be underreported in Lombardy and New York City, which, unlike Hubei, were still developing outbreaks at the time of this analysis, is shown in the bottom left panel. And notably, the relative order of magnitudes across locations remains unchanged. Substantial differences in documentation rate are also visible as shown in the top right panel, with consistently low documentation rates across locations, rates that are further reduced when conducting a sensitivity analysis in which deaths in Lombardy and New York City are once again assumed to be underreported, as is shown in the bottom right panel. Despite low documentation rates across locations, though, all three populations remain vulnerable to a new wave of infections in summer 2020, which is when this paper was in preparation for publication. More specifically, our models suggest that only 1.3% of Hubei, 13.8% of Lombardy, and 22% of New York City were infected by the end of our modeling periods for each location, the latter of which has since been confirmed empirically via serological survey from around that period, summer 2020. Given the susceptibility of all three locations to further transmission of SARS-CoV-2 in summer 2020, we simulated the possible impact of various shelter-in-place policies to curb transmission in the event of a new wave prior to the widespread availability of sufficiently effective vaccines, with a focus on age group-specific policies. Here, each column shows a different level of physical distancing by the population of interest, where contacts between all age groups are reduced to the given percentage of their starting value. The x-axis within each plot shows the result when the given fraction of a single age group shelters in place in addition to physical distancing by the rest of the population. And the result of this combination of sheltering and distancing is represented by a bar, where the color of the bar indicates the age group which engaged in sheltering, as is shown in the key. The height of the bar yields the total fraction of the population infected or the number of deaths in the population in that scenario. Each row gives the results for a single location, where the first two plots show the fraction of the population which is newly infected in the new wave, and the next two plots show the number of new deaths which occur. Via our simulations, we found that sheltering in place by a single age group had the potential to produce protective effects against transmission for the entire population. But which age group had the greatest impact varied across our three locations, highlighting the importance of capturing heterogeneity both within and across populations. Moreover, the impact of sheltering in place was itself impacted by the level of physical distancing undertaken by the rest of the non-sheltered population. Here, 50% and 75% contact rates, which represent 50% and 25% reductions in number of contacts, are shown, with starkly different outcomes with respect to infections, shown left, and deaths, shown right, in our three populations of interest. This work suggests that partial population sheltering rather than universal lockdowns, combined with physical distancing by the remainder of the population, might be a creative policy solution for reducing COVID-19 transmission in settings where effective vaccines have yet to reach the population at large, or in the future where variants of concern might be capable of vaccine escape. But recommendations regarding who should shelter have to be population specific. Given the impact of physical distancing as a supplement to partial population sheltering, we also provided a list of policy recommendations to improve the feasibility of physical distancing in our paper. Recommendations that are still relevant today in under-vaccinated regions and areas facing new outbreaks of more transmissible variants, something that's super relevant right now as we are in the midst of a surge. These include, but are not limited to, the implementation of shift work, staggering of work shifts, and cohorting of workers in workplaces, one-way aisles and age group-based shopping hours for essential businesses like grocery stores, pharmacies, and so on, staggered admissions for non-essential businesses like gyms and restaurants, and remote worship services for religious congregations. More recommendations, including the feasibility of sheltering in place within the work from home paradigm, are elaborated upon in the supplementary materials as well for anyone who might be interested. This all said, though our ABM structure has been peer-reviewed and published and has been out in the world now for a couple of years, we're still working on improving it through related and ongoing work that builds off the structure I just presented and applies it to other locations of interest. Internationally, we've expanded our model to India, and domestically, we've started work on developing state-level models that incorporate labor sector and occupation into the Asian characteristics as defined for each population of interest. Both here and abroad, we're also working on modeling more equitable vaccination deployment strategies that exploit transmission heterogeneity, the fact that not all individuals are as likely to contract or spread SARS-CoV-2 as others, to inform risk-based immunization, particularly in regions with a limited supply of updated booster shots, as well as within the context of high-demand novel vaccines, such as intranasal and variant-resistant technologies that are currently in development. Finally, we're starting to integrate other non-pharmaceutical interventions like masks and air filters into our model structure as we learn more about how different types of masks and air filters reduce inhalational transmission risk, allowing us to incorporate them alongside physical distancing, sheltering, and vaccination in our model. Without question, this is an active area of research where we expect to continue improving upon our published work to better inform the way that we make policy decisions moving forward, and we're really excited to see where our ongoing work takes us. Now, let's go ahead and dive into another research area of interest at the intersection of Comp-Epi and the COVID-19 pandemic: smartphone mobility data for health policy evaluation. The paper I'll be presenting in this research area was published in the Journal of Public Health for those who are interested in reading it. Using mobile network data for all 50 US states and Washington, D.C., there were 3 research questions of interest that we wanted to address in this paper. First was pre-existing state-sanctioned paid sick leave, or PSL, as I like to call it, associated with decreased workplace mobility during the first 5 months of the pandemic, indicating an increased level of compliance with stay-at-home orders that were issued in early spring 2020. Second, assuming that this association did exist, was it modified by the passage of the Families First Coronavirus Recovery Act, or FFCRA, on April 1st, 2020. For those who may be unfamiliar, this was a nationwide policy that provided 2 weeks of emergency sick leave to all American workers during the earliest months of the pandemic. And third, was this association robust when we adjusted for other state-level variables that might have impacted early pandemic workplace mobility? There are a lot of really cool results I want to share today that begin to answer these 3 questions, so I'm only going to offer a really cursory look at the methods we used for this particular study before jumping into our findings. The paper is cited throughout these slides, though, for anybody who'd like to dig into the more technical aspects. So to answer our research questions, we first turned to Google Mobility Reports to collect workplace mobility data for the earliest months of the pandemic, which was our primary outcome of interest. We then integrated these data with additional data sets for each of the 50 states and Washington, D.C. The data set for the primary exposure indicated the presence or absence of a pre-existing paid sick leave policy in any given state. We also curated a data set of economic variables, such as wage policies, worker protections, dominant labor sector, so on and so forth, epidemiological metrics like COVID-19 cases and deaths, and sociodemographic factors, including median household income, state gross domestic product, commuting patterns, and plenty of others. To test associations between our outcome and exposure of interest, we used a mixed effects interrupted time series model with nested random effects for state and month. Both an adjusted model and an adjusted model for economic, epidemiological, and sociodemographic variables that were significantly associated in bivariate analysis were ultimately constructed. Our findings are maybe best showcased by this spaghetti plot, though, where the y-axis represents the % change in workplace mobility away from pandemic baseline. Each line represents one state, and the blue lines represent states that had state-sanctioned paid sick leave policies before the pandemic began, while the orange lines represent states that didn't. The black vertical line represents when the FFCRA was put in place. Again, let's recall that this was a nationwide policy that granted all workers across the country with 2 weeks of guaranteed sick leave, irrespective of pre-existing state-level paid sick leave policy. Meanwhile, the dashed gray box indicates when states issued stay-at-home policies. As is very clear from this plot, though, even after the FFCRA was passed, states with pre-existing paid sick leave policies saw more pronounced drops in workplace mobility during the first 5 months of the pandemic, both during and after stay-at-home policies were issued. This suggests that workers who fell ill with COVID-19 were able to take time off more readily in those states than workers in states without state-sanctioned paid sick leave, likely due to the presence of pre-existing cultural norms and operational infrastructure, such as PSL-aware staffing systems. In other words, though the FFCRA applied to all American workers, those who benefited from it most lived in states where paid sick leave policies existed at the state level prior to the pandemic. Most important of all, this association remained intact after adjusting for state-level economic, epidemiological, and socio-demographic variables. Even with adjustment, we found that the presence of pre-existing state-sanctioned paid sick leave policies were associated with decreased workplace mobility between February and July 2020. A table containing a very lengthy list of variables that we bivariately associated with workplace mobility and their significance once included in our multivariable model is available in the body of the paper, which is cited at the bottom of this screen. The policy recommendations for a policy evaluation study like this one usually speak for themselves, but for the sake of driving home the point, let me be very clear. This study shows that universal paid sick leave is an essential policy within the context of crisis preparedness and compliance with crisis responsive policies. In the current context, the crisis is the COVID-19 pandemic, but stay-at-home policies apply to a broad range of crises beyond public health emergencies, including natural and man-made disasters. Moreover, pre-existing operational infrastructure to deploy paid sick leave is necessary for crisis responsive policies like the FFCRA to be as accessible and as equitable as possible. Without universal paid sick leave, workers who live in states with state-sanctioned paid sick leave will always be better off than those who don't, even when short-term nationwide policies like the FFCRA are passed. Beyond the concrete policy recommendation that universal paid sick leave should be implemented in preparation for future crises, our experiences working on this investigation also make really clear where advocacy for this policy should take place. Traditionally, advocacy for paid sick leave has been centered around labor organizing, rightfully so, but our study shows that advocating for this policy in the public health policy context is also warranted. Moreover, the pandemic itself has highlighted why universal paid sick leave is not just a labor policy and a public health policy, but also a social justice policy. Our multivariable analysis showed that absence of paid sick leave likely has disproportionate impacts on essential and socioeconomically disadvantaged workers. Moreover, my team's ongoing work with collaborators in economics has shown that these groups of workers are themselves disproportionately BIPOC, or Black, Indigenous, and people of color, and thus are also at disproportionate risk of adverse health effects, especially during public health crises. To build on the work in this study, my team is currently examining the relationship between state-level paid sick leave and vaccine uptake. Surveys by our colleagues have shown that side effects, particularly those that interfere with ability to work, remain a notable barrier to vaccine uptake across the US. Beyond expanding our work on paid sick leave specifically, we're also currently in the process of expanding our work at the intersection of labor and public health more broadly too, via collaborations we've established with a consortium of 14 state health agencies across the US and counting. One of our ongoing studies involves using person-level death certificate data from this consortium to examine cause-specific excess mortality among essential workers across labor sectors during the pandemic. Of course, policies like paid sick leave or lack thereof don't exist in a vacuum. And just as our policy landscape impacts our health, our political climate impacts our health too, which leads us to the third and final study that I'll be covering today, which was published in the Lancet Digital Health. In the broad research area of utilizing search query and news media data for monitoring health misinformation, this paper focuses on the public health impacts associated with a highly politicized and publicized misinformation event that I'm sure many of us remember all too well. President Trump's April 2020 remarks regarding the off-label use of disinfectants as a COVID-19 therapeutic. For those who might need a refresher, though, let me read President Trump's remarks for you now verbatim. Quote, "I see the disinfectant, where it knocks it out in a minute. 1 minute. And is there a way we can do something like that? By injection inside or almost a cleaning. Because you see, it gets in the lungs and it does a tremendous number on the lungs. So it would be interesting to check that. So that you're going to have to use medical doctors with. But it sounds interesting to me." Following this particular statement during a White House press briefing on April 23, 2020, my team was interested in answering 3 specific research questions. First, how did President Trump's remarks impact the behavior of the public with respect to interest in purchasing, drinking, and injecting disinfectants? Second, how long did the impact of his remarks last? And finally, was this misinformation event associated with population level increases in adverse health effects like poisonings? Like the paid sick leave study, there were a wealth of fascinating findings that we discovered through this investigation. So I'm going to keep my discussion of the methods brief and focus primarily on the results. But please do feel free to read the paper cited here and the accompanying technical appendix if you'd like to learn more. To start addressing these questions, we first turned to internet search query data from Google to get a handle on what kinds of disinfectants the general public was searching for both before and after April 23rd, 2020. Google search query data are fractional and relative. When interest in a search term reaches a peak for a given time period, this means that that term was most popular at that point in time, and whichever term in a series of terms was most popular among them peaks at 100. Here we can see that Lysol was the most popular term among the 9 disinfectants considered, and that it peaked around April 23rd, 2020. Other popular disinfectants included bleach and Clorox, with the remainder falling away from the pack. With our initial search query analysis under our belts, we curated a set of search terms to represent 4 topics of interest. First, purchasing; second, drinking; and third, injecting disinfectants, as well as fourth, poison control, a proxy indicator for possible poisonings following the off-label use of disinfectants. As is clear from the search terms considered, we chose to focus on the 3 most popular disinfectants that appeared to peak around April 23rd, 2020, Lysol, bleach, and Clorox. We pulled data from Google search trends for these search terms, but we also pulled news media data pertaining to these topics as well, so that we could get a debiasing procedure in place to separate interest in President Trump's remarks due to media-generated interest from true interest in the off-label use of disinfectants. Debiasing was particularly important in this investigation, given how rapidly interest in these remarks proliferated across information networks, especially news media networks, given that the misinformation event itself occurred at a press briefing. The autoregressive machine learning procedure designed to debias the search query data of media-generated interest is detailed at length in the supplementary materials that accompany this paper for those who might be interested. Prior to debiasing the search query data of media-generated interest, we plotted our raw search query data, and the results, which are shown here, are absolutely stunning. The action-oriented searches that reflected off-label use of disinfectants, namely drinking and injecting disinfectants, peaked immediately following Trump's April 23rd remarks. Then, rather damningly, interest in poison control peaked the very next day, results that are consistent with disinfectant-related poisoning reports subsequently noted by the American Association of Poison Control Centers. Moreover, interest in these topics remained increased for an entire week following the misinformation event, suggesting that while most of the associated impact on population level behaviors probably occurred soon after the event itself, the impact didn't dissipate immediately, potentially due to network effects that allowed news coverage of the misinformation event to continue propagating. Debiasing to minimize the news media generated interest in these topics marginally blunted results across the topics of interest, but as is shown in these 4 charts, the overarching trends described in the previous slide remained consistent. Of course, we can't infer causation from this work alone, but the fact that internet search interest in poison control centers peaked after queries regarding off-label use of disinfectants suggests that search query data could be used as part of an early warning surveillance system for poison control centers in the future, a need that may be increasingly dire as false cures and prophylactics for COVID-19 and many other diseases continue to be propagated by those in positions of power. Which brings us to the policy recommendations that my team made following this study. First and foremost, science communication at multiple scales will be necessary to combat sources of misinformation, including elected officials, which is particularly relevant right now as we gear up for the 2024 presidential election here in the US. It's because of this policy recommendation that I recently served on a National Academies Committee specifically designed to advise the federal government on health communication strategies. Second, a surveillance system for public health misinformation should be established using digital data sources that allow us to monitor population level behaviors following misinformation events. But by designing this kind of system specifically for healthcare and safety service providers, decision-making tools like an early warning system for poison control centers, like the one that I just mentioned, can effectively be brought to fruition. With an eye towards establishing a surveillance system for public health misinformation, my team is currently pursuing a geographic analysis to accompany the temporal analysis presented today to uncover spatial heterogeneities and population level behaviors, and thus vulnerability, following misinformation events, as well as sociodemographic risk factors that accompany this vulnerability to enable things like hotspot prediction of adverse health effects in response to misinformation events. We're also working on incorporating additional data streams like Reddit to glean deeper insights into behavioral impacts following other misinformation events, including those that pertain to vaccines. And on that note, thank you all so much for listening. I know that I have covered a ton of material today, but I hope that I've effectively showcased a sampling of the contributions that computational epidemiology can make within the context of the ongoing pandemic and public health more broadly. Now, with that said, I would be very happy to answer a few questions. Thank you all again.
Thank you so much, Maya, for that extensive body of work and suggestions towards other work that you didn't have time to present here today. Really lots of impact was created through this work. I'd like to put it out to questions. I have, of course, many questions, and I can table some of mine till after, but actually maybe to get us started, I'll start with one question, and everyone else on here, please feel free to share your questions. Raise your hand, and we can pass the questions around. So you touched on a point in relation to this last study you presented on the impact of the misinformation on detox. I don't. It's almost too ridiculous to say it. So I'm impressed that you can do it with a straight face. But you touched on causality, and I think those figures that you showed at the end were extremely telling and kind of, maybe a very strong statistical causal model there really isn't going to go that far beyond the findings that you were able to find. But maybe you could touch on more generally, like what you think the role of causality is in particularly the last two research studies that you talked about, with the paid sick leave policy being implemented at staggered times across these different states. That seems like a good natural experiment to be able to run. But what's the role of that in terms of getting real world policy level analysis? I mean, some things are just so clearly evident on their own. So I'd love your thoughts on this question.
Yeah, that's a great question. So maybe to back up on what the intention of this type of work is, ultimately we do these sorts of analyses because we want to influence policy, right? So then the question becomes, what is most beneficial to the policy advocates where they're advocating? And so this is something that requires these deep relationships with people whose day-to-day lives are committed to making these policies, to writing bills and getting them passed, right? So that means having interactions with your policymakers and asking them, what kind of studies do you need in your repertoire right now to help make this case, whether it be at the state level or at Congress? And so those are the sorts of questions that we are actually often grappling with. So for example, the paid sick leave study, one of the things that we heard from paid sick leave advocates was, we have lots of traditional causal inference models for paid sick leave. It is very obvious from the statistical literature that paid sick leave is a good thing. It has really important and fantastic benefits to people's health and longevity in the long term. It has great impacts on family life and on well-being in general. We know that. The causal literature is there. I think more or less economists, at least health economists, feel that the causal literature is there. So what they wanted was, can you show us with really big numbers what the actual effect of this thing was during the pandemic. And so this is exactly where mobile phone data is super helpful, right? This is like millions and millions of people's mobile phones showing where they have moved and gone and been over the course of the first 5 months of the pandemic. And so this study was really in response to what policymakers and policy advocates felt was missing from their current repertoire of evidence for why this policy should be a universal policy, right? And so in general, I feel, and this is a philosophy that I have throughout my lab's work, is that if you want to do policy change related work, you really need to be able to identify not just where the gaps are in the scientific literature, but where are the gaps in the policy literature, right? These are two separate things. And not only that, what do policymakers really feel is missing from their own argumentation, right? What additional evidence do they need? And, there have been many instances where what they do need is a traditional causal inference or causal discovery reasoning style paper. So an example of that I didn't get to present today, but I'll touch on briefly now is early in the pandemic, during kind of the first phase of vaccine rollout here in Massachusetts, we had something called the Massachusetts Vaccine Companion Program. And this was a really unique program in which the elderly who were within the kind of first group of people to get vaccinated were allowed to bring with them a companion, anybody that they wanted, right? It could be a family member who was driving them. It could be a neighbor. It could be some random kid off the street, whoever they wanted, right? As long as they had FDA clearance to be vaccinated, they could bring that person and that person would also be vaccinated. And so the reason that the Department of Public Health decided to try this out is because they were having a lot of trouble getting older people vaccinated. It's for obvious reasons, right? I mean, it's hard if you don't drive, maybe you do drive, but you can't figure out how to manage the online appointment system. I think all of us remember how very early in the pandemic, the only way you could make a vaccine appointment was online. And if you are a 75-year-old and have not used the computer in the last year, this is a really difficult situation for you. So to create an incentive to have younger people help their older friends, family, neighbors make these appointments, they added this incentive that, okay, if you bring an elderly person, you can get vaccinated too. This was a really, really novel incentive program and one that has had, I think, really kind of resounding effects on how we think about the way that incentive programs should be designed for vaccines, because it's quite different from, say, the incentive programs that, gave you a lottery ticket or gave you a free, Starbucks gift card or what have you, right? It's not a monetary incentive. It is really a public health incentive, right? So what the Massachusetts Department of Public Health wanted my team to do is, can you tell us whether this had any effect, like whether it actually improved vaccine uptake in people 75 plus, and whether it had any trickle down effects on younger populations. And the reason that they wanted a really kind of standard causal inference approach to this is because they wanted to be able to defend doing this sort of thing in the future. This was the first time that something like this had ever been done. So that's exactly what we did. We did a very kind of straight and narrow causal inference study on this particular policy. And lo and behold, it showed that the program worked really well. It had fantastic effects on 75 plus age group, but it also had fantastic effects on younger people too, who were able to get vaccinated faster. And what we did is we essentially compared Massachusetts to a cohort of other similar states that did not have a similar program in place. And so that's one example of a situation where your policymaker is telling you to be able to actually defend doing this program again, we need actual causal evidence that this worked, right? And so that's why we did that. And I have plenty of other examples, but I'll stop there. So in general, the way that we navigate this, whether we're doing a causal inference or reasoning or discovery study versus doing a different type of study for these sorts of policy evaluation questions, is often based on what the policymakers themselves believe is missing from their body of evidence. And as a result, we get to have really, I think, substantial interplay with policymakers, which is the best part of this particular job, in my opinion.
Well, okay, that was very comprehensive. Thank you, and thank you for that example. I think these are the much broader, more impactful ways to look at the kind of questions that I asked. So, I have heard that it might not be possible for people to raise their hand, but a couple people have been sharing their questions here in the chat. I'd like to call on Keith Burkhart, who has a question. Keith, if you are able to unmute yourself. Yeah.
Absolutely. And thank you, Abigail. And this is a great talk, Maya. The question I had was, so you were able to look at Google searches, and as you were mentioning, the ultimate limitation is that these are normalized. You don't know any value, how those values between 0 and 100 correspond to actual numbers of searches. I don't know if there's any way to determine this, maybe from mobility data or something, but for this to be, I would expect very useful as an early warning system. We would want to know roughly how many actual calls will that correspond to in the poison control, or how big a deal is it for one to send their own posts and own announcements saying that this is misinformation. Like, we have these searches, but do you know roughly how many poison control center calls that was? And that could give us a baseline in the future if you say, okay, this value is, 20 or 30 points higher than before. Is that a big deal or not?
Yeah, that's a great question, Keith. So this is something that we're working on right now. Those numbers do exist. So one really great thing about the Poison Control Centers of America is that they release these really comprehensive reports. So you don't really even, I mean, anybody in the public can go read them, which is great, but we've also established contact with them because this is something that we want to work on with them. One thing that we are thinking about doing, and this is where the regional analysis that we're working on right now comes in. One of the better ways to kind of deal with this normalization problem is to exploit the geographic heterogeneity that existed with who was actually searching for this stuff and where, and how that corresponded to poison control calls in their individual state. So that's something that we're using right now to try to disentangle this a little bit, because you're absolutely right. The fact that the numbers are normalized is one of the biggest limitations of Google search trends. We know why it exists, right? It's a privacy preserving technique, and I'm certainly not going to advocate for getting rid of it because I do think that it does what it's intended to do. At the same time, I think that for this particular use case, it is probably really going to serve us to be able to look at the geographic heterogeneity and see what we can learn from state calls, right? So often when you call poison control, it's not just to like an American national hotline, right? You often call to a state hotline. And so that's some of the work that we're navigating right now. And whether we can see, just like you said, a baseline emerge, and whether that baseline is different from place to place, I don't think it's going to be homogenous. That's been my interpretation so far of the kind of very initial work that we've done. Again, this is very preliminary and exploratory, but my sense is that this is not exactly a one-to-one situation where it's the same for every state. And so trying to figure out what that signal is, or rather, what we're trying to do right now is maybe less find a factor by which to, multiply and normalize everything else, but rather can we identify a threshold beyond which, if interest beyond this is reached, we really do need to start deploying things like active, not only like surveillance systems, but active efforts towards education, mitigation, management before anybody injects themselves with bleach. So it's an interesting situation. I think that for better or for worse, the reality is that this particular event is not the only problem that we've had here in the US, and not all of them have to do with COVID-19 either. One that does have to do with COVID-19 is interest in ivermectin and the amount of ivermectin that people have bought, used, and consumed during the pandemic. And we have a paper that is coming out soon about that kind of starts to disentangle what geography can tell us, right? So in this bleach study, we've looked at just temporality, and it tells us something interesting. But when you start digging into the geographic heterogeneity, that's when you start to really learn things that might be super helpful for folks at places like poison control. So just to say, I completely agree. Normalization is probably the biggest limitation of this data source. And I think that combining temporal analyses of GST with geographic analyses is one of the ways that we can start to, produce things like thresholds that might actually be useful for places like the American Poison Control Centers.
Great, thank you.
Thank you. We have a question from Adam Russell. Adam, are you here? Can you ask your question or should I? Yeah. So I see Adam's. Okay, I will ask. So I'll just repeat this question. So given issues of free speech and the need to walk the narrow corridor between a two weak state and a two controlling state, in your opinions, should someone be held accountable for health misinformation? Info that turns out to be wrong, that's the definition. How about disinformation, i.e. info that people know is false? Who, why, and how? And what else do you think we should do to fight mis or disinformation?
Yeah, this is a really, really important and complex question. And I, as an individual, have opinions. Now, those opinions are often, I think, nebulous and responsive to the things that are happening on a day-to-day basis. I think for many of us, if you had asked us before the pandemic, one thing that we might have said is, oh yeah, like it's so clear when things are misinformation, especially like in the vaccine space, right? If you were working on measles and mumps vaccination misinformation before the pandemic, which I myself was, and I'm sure many of the people on the call were as well. But what's happened during the pandemic is that all of us on the line are scientists. We know how science works, right? Often science does not get it right the first couple of times you try something, and it is an iterative process, right? So you learn something and then you learn something new that essentially abrogates the thing that you knew before, right? And so that is the beauty of science. It's also what makes even things like defining what is misinformation really difficult. So if, for example, you were to look at tweets from January 2020 from, some of the brightest minds in infectious diseases, they were certainly saying things that are, not true, right? They were saying things like asymptomatic transmission of SARS-CoV-2 is very unlikely. And with the knowledge we had then, it probably was unlikely, but it is the most common means of transmission now, right? So that's just one example of how, was the intention there misinformation? Was it? Certainly it wasn't disinformation, right? Is it misinformation when we look on this in retrospect? And so I'm kind of like adding an additional question to the question that's been posed here, right? Which is not as helpful as answering it maybe, but I do want to kind of broaden the question because I think that this piece of when we look back on something and are trying to determine whether or not that was misinformation, right? Because so much of what we do in machine learning is looking at the past and then trying to see how it can help us in the future, right? And so what we're learning by looking in the past right now is, well, we said a lot of things that were wrong, and that's maybe not that, uncommon in science because we didn't know any better then, but it had the same effect, right? So because of these beliefs that we had about how this infectious disease system would work and early on in the pandemic, because of these belief systems that we had and what we said then, people now, the general public now, still largely believes, oh, asymptomatic transmission doesn't happen, even though we know that it does happen now, right? And so I think that that's one thing that I've personally been really grappling with, and I think it's one of the things that makes, like prosecuting somebody for misinformation really difficult. Because first of all, I think in general, it is difficult to know the intention. It is, in fact, easier to tell the difference between disinformation than misinformation, right? You can usually tell with some digging whether somebody knew that something was false before they spread it, or they have some sociopolitical motivation for doing this. And we have a couple of ongoing projects, especially focusing on the Ukraine crisis, that looks at this from the lens of the Kremlin, right? So there are those instances where it's often easier to identify. What is harder to do is this situation where I'm sure many of us even unknowingly spread misinformation early in the pandemic because we didn't know any better. Now, does that mean that we are wrong or bad? No, it doesn't, right? That's the nature of science. The knowledge has shifted and changed. And so I think figuring out how to think about this is going to be a really important paradigm that we need to shift in the coming years, because this is really, really complicated. The way that science is, it is in some ways prone to misinformation because we have this tendency to learn things that are new that abrogate the things that are old, right? And so that's my feeling. I know that adds an additional question instead of answering the one that you've asked, Adam, but thank you for the fantastic question.
All right. That was definitely, as Adam said, a thoughtful answer, right? So, and one that takes in what we've been learning over these last 5 years. So we're at time. I'm sure there are more questions. Where is the best place for people to reach you, Maya, if they have further questions?
Yeah, that's a good question. So the best place to reach me is via email. So let me pop that up here. Right there at the top. And of course,
Right.
Trisha and Abby have access to my email too. So feel free to ask them if you don't have a chance to take this down. But yes, via email is fantastic. And yeah, I really do hope to stay in touch with folks I won't get a chance to talk with one-on-one today, but I know that I'm meeting with several people as well.
Yeah. So thank you for that. Thanks for making that all that time for the continuing the conversation. And I look forward to talking to you later today myself. Thanks again, and take care.
All right. See y'all, everyone.
Thank you, Maya.
All right.